Pregnancy is one of the most carefully monitored periods in a person's medical life, and for good reason. The human body during those 9 months undertakes a biological reorganization of extraordinary complexity, and the structures that support a developing baby must form, position, and function with precision. When they do not, when one of those structures deviates from its expected position or behavior, the consequences can range from manageable to serious, and the difference between those two outcomes is almost always determined by how quickly the condition is recognized and how effectively it is managed. Placenta previa is one of those conditions. It is not common, affecting approximately 1 in 200 pregnancies in developed countries, but it is one of the most important obstetric complications for both the pregnant person and the healthcare team to understand clearly, because it is a condition that, when identified and managed appropriately, can be navigated safely in the vast majority of cases, and it is a condition whose primary warning sign, painless vaginal bleeding in the 2nd or 3rd trimester of pregnancy, should never be ignored, minimized, or attributed to something less serious without proper evaluation. Today, from the perspective of obstetrics and maternal-fetal medicine, we are going to explain what placenta previa is, why it occurs, what it feels like and does not feel like, how it is diagnosed, what the options for management are, and what outcomes look like for the people who experience it. We are going to provide the clear, specific, evidence-based understanding of this condition that every pregnant person, every partner, and every family member who accompanies someone through pregnancy deserves to have. Let us begin with the anatomy and the normal position of the placenta, because the problem of placenta previa is fundamentally a problem of position, and understanding the normal tells us everything we need to know about the abnormal. As we discussed in our placental development video, the placenta forms from the trophoblast cells of the implanting blastocyst and attaches to the uterine wall at the site of implantation. In the vast majority of pregnancies, the blastocyst implants in the upper portion of the uterine cavity, the fundus or the anterior or posterior walls of the upper uterine segment, and the placenta develops in this position, growing outward from the implantation site as the pregnancy progresses. The lower portion of the uterus, called the lower uterine segment, is the region that will gradually thin and stretch in the 3rd trimester as the uterus prepares for labor and delivery. It is this region that transitions into the cervix, the fibromuscular structure whose dilation is the key event of labor. The cervical os, the opening of the cervix, is the gateway through which the baby must pass during a vaginal delivery. In a normally positioned pregnancy, the placenta is located in the upper uterine segment, well away from the cervical os. The lower uterine segment and the cervix are unobstructed, allowing the baby to descend and pass through during labor without any placental tissue in the way. Placenta previa occurs when the placenta implants or migrates to cover part or all of the internal cervical os, the inner opening of the cervix. When placental tissue overlies the os, it creates an anatomical obstruction that makes vaginal delivery impossible and creates the risk of severe bleeding, because the thin tissue of the lower uterine segment and the placenta covering the cervix are subject to the shearing forces of uterine contractions and cervical dilation in ways that cause bleeding from the placental bed. The classification of placenta previa reflects the degree of cervical os coverage. Complete placenta previa, also called total placenta previa, occurs when the placenta completely covers the internal cervical os. Partial placenta previa occurs when the placenta covers only part of the os. Marginal placenta previa occurs when the edge of the placenta is at or within 2 centimeters of the internal os without actually covering it. And low-lying placenta describes a placenta whose edge is between 2 and 3.5 centimeters from the os. This classification matters clinically because the degree of os coverage determines both the bleeding risk and the likelihood of the condition resolving before term, a concept called placental migration that we will discuss in detail shortly. Understanding why placenta previa occurs requires understanding the factors that influence where implantation happens in the first place, and why some placentas end up in positions that create this complication. The most important risk factor for placenta previa is a history of previous uterine surgery, particularly previous cesarean section. When the uterus is incised during a cesarean delivery, it develops a scar in the lower uterine segment, the very region that placenta previa affects. This scar alters the vascularity and the implantation characteristics of the lower uterine segment in subsequent pregnancies, making it more likely that a blastocyst will implant in that region and that the placenta will develop in a low-lying or previa position. The risk of placenta previa increases with the number of previous cesarean deliveries, a clinically important consideration as the global cesarean rate continues to rise. Research published in the journal Obstetrics and Gynecology found that the risk of placenta previa approximately doubled with one previous cesarean, increased further with two, and continued to escalate with additional cesarean deliveries. For women who have had 3 or more cesarean sections, the risk of placenta previa in subsequent pregnancies is substantially elevated compared to women without prior uterine surgery. Other risk factors include previous uterine surgery for fibroids, a history of uterine curettage, advanced maternal age, multiple gestation, multiparity, tobacco smoking, and the use of assisted reproductive technologies, all of which are associated with implantation site variability or alterations in uterine vascularity that increase the probability of low placental implantation. The concept of placental migration is critical for understanding the natural history of placenta previa and for counseling patients whose previa is diagnosed early in pregnancy. The term migration is somewhat misleading. The placenta does not literally move through the uterine tissue. What occurs is that as the pregnancy advances, the upper uterine segment grows disproportionately more than the lower segment, effectively carrying the placenta upward relative to the cervical os as the uterus expands. Simultaneously, the development of the lower uterine segment in the 3rd trimester creates new uterine tissue below the placental edge, increasing the distance between the edge of the placenta and the os. The result of this differential growth is that many placentas diagnosed as previa in the 2nd trimester resolve to a low-lying or normal position by the 3rd trimester. A low-lying or marginal previa diagnosed at 18 to 20 weeks resolves in approximately 90% of cases by 32 to 36 weeks of gestation. This natural history has important implications for clinical management. A diagnosis of placenta previa at the anatomy scan performed between 18 and 20 weeks of gestation is not necessarily a diagnosis that will persist to delivery, and the appropriate response is follow-up ultrasound rather than immediate clinical alarm. The cardinal symptom of placenta previa is painless vaginal bleeding in the 2nd or 3rd trimester of pregnancy. The word painless is diagnostically crucial. It distinguishes placenta previa bleeding from the painful bleeding of placental abruption, which occurs when the placenta separates from the uterine wall before delivery and is characteristically accompanied by significant uterine pain and tenderness. Placenta previa bleeding is painless because it arises from the shearing of placental tissue at the cervical os, a process that does not stretch or distort the uterine muscle in the way that abruption does. The first episode of bleeding typically occurs in the late 2nd or early 3rd trimester, most commonly between 28 and 32 weeks of gestation, and is often described as a sudden onset of bright red vaginal bleeding without warning, without pain, and without any precipitating event. It may be light or it may be heavy, requiring urgent medical attention. The bleeding typically stops without intervention as the lower uterine segment relaxes, but it almost invariably recurs, with subsequent episodes typically more significant than the first. This pattern, recurring episodes of painless bleeding, each potentially more severe than the last, is the clinical signature of placenta previa and is the reason that the condition requires careful management once diagnosed. Each bleeding episode is a potential medical emergency, and the cumulative blood loss over multiple episodes can produce significant maternal anemia that requires treatment. Before we continue, here is a pause specifically for anyone watching this who is pregnant or accompanying someone through pregnancy. If you experience painless vaginal bleeding at any point in pregnancy, even a small amount, the correct response is to contact your obstetric provider or proceed to an obstetric triage unit for evaluation. This is not a symptom to monitor at home and report at the next scheduled prenatal visit. It is a symptom that warrants same-day evaluation. Drop a comment below right now if you have questions about what we have covered so far, or if this information has clarified something you have wondered about during pregnancy. We read every comment. The diagnosis of placenta previa is made by ultrasound, and specifically by the measurement of the distance from the placental edge to the internal cervical os, a measurement that requires the precision of transvaginal ultrasound rather than the transabdominal ultrasound used for standard fetal anatomy assessment. Transabdominal ultrasound is adequate for identifying a placenta that is clearly in the upper uterine segment or clearly covering the entire os, but it is not sufficiently precise for the measurements that determine whether a low-lying or marginal previa is present. Transvaginal ultrasound, in which a small ultrasound probe is gently introduced into the vagina to image the lower uterine segment and cervix from close range, provides the most accurate measurement of the placental edge-to-os distance and is the standard of care for confirming or excluding placenta previa when transabdominal imaging is uncertain. Multiple studies have documented the safety of transvaginal ultrasound in the setting of placenta previa, with no evidence of increased bleeding risk from the procedure when performed carefully by trained operators. Digital cervical examination, the manual examination of the cervix, should be strictly avoided in any pregnant patient with suspected or confirmed placenta previa, because direct mechanical contact with the placenta at the OS can precipitate immediate and severe hemorrhage. This contraindication is absolute and must be communicated clearly to every member of the healthcare team managing the patient. Magnetic resonance imaging, MRI, is used as an adjunct to ultrasound in specific clinical situations, particularly when placenta accreta spectrum disorders are suspected. Placenta accreta spectrum, the abnormal invasion of the placenta into the uterine muscle or surrounding structures, occurs with significantly elevated frequency in women who have both placenta previa and a history of cesarean section, because the placenta covering the scarred lower uterine segment may adhere to or invade the scar tissue. The combination of placenta previa and prior cesarean section is therefore evaluated with particular vigilance for the coexisting accreta spectrum that would substantially increase the surgical complexity and hemorrhage risk at delivery. The management of placenta previa is determined by the degree of coverage, the gestational age at diagnosis, the presence and severity of bleeding, and the presence of any coexisting conditions including accreta spectrum. For women diagnosed with placenta previa in the second trimester who are asymptomatic, the initial management is expectant, with instructions to avoid vaginal intercourse, avoid digital cervical examination, and maintain easy access to obstetric care. Follow-up ultrasound at approximately 32 to 36 weeks of gestation reassesses the placental position and determines whether the previa has resolved or persists. For women who experience bleeding episodes, management depends on the severity of the bleeding and the gestational age. Light bleeding that stops spontaneously in a woman remote from term may be managed expectantly as an inpatient or outpatient with close monitoring and anemia treatment if needed. In pregnancies complicated by significant bleeding, maternal hemodynamic instability, or signs of fetal compromise, emergency cesarean delivery may be required regardless of gestational age. For women with complete placenta previa persisting near term, the standard management is elective cesarean delivery at approximately 36 to 37 weeks of gestation, before the onset of labor, which would inevitably cause bleeding from the placenta covering the cervix as uterine contractions cause cervical dilation. Corticosteroid administration, betamethasone or dexamethasone, is given between 24 and 34 weeks of gestation to women at risk of preterm delivery from placenta previa to accelerate fetal lung maturity and reduce the risks of prematurity-related complications if early delivery becomes necessary. Living with a diagnosis of placenta previa requires specific practical adaptations that are not always clearly communicated at the initial diagnostic visit. Activity restriction is the most universally recommended behavioral modification. Vigorous physical activity, high-impact exercise, heavy lifting, activities that significantly elevate intra-abdominal pressure, is generally advised against. Pelvic rest, the avoidance of vaginal intercourse and anything that might precipitate uterine contractions, is uniformly recommended for all women with placenta previa throughout the period that placenta previa is present. Travel considerations are relevant for women with placenta previa, particularly as pregnancy advances into the third trimester, because placenta previa bleeding can escalate rapidly from light spotting to significant hemorrhage. Being far from obstetric care when bleeding begins creates a serious risk. Most obstetric guidelines advise women with complete or partial placenta previa in the third trimester against extended travel to locations more than 30 to 60 minutes from a hospital with obstetric surgical capabilities. Emergency preparedness at home is a practical component of management that every woman with placenta previa should discuss with her obstetric team. This means knowing exactly what constitutes an emergency, having a clear plan for how to get to the hospital immediately, having a bag prepared for hospital admission from the middle of the second trimester onward, and ensuring that the people in one's immediate environment understand the diagnosis and know what to do if bleeding occurs. The psychological dimension of placenta previa diagnosis deserves honest acknowledgement. Research on the psychological experience of women with placenta previa has documented elevated rates of anxiety, depression, and pregnancy-specific distress compared to uncomplicated pregnancies. a finding that is entirely understandable given the genuine uncertainty and the medical intensity of the monitoring and management that accompanies the diagnosis. The restrictions associated with placenta previa, pelvic rest, activity limitation, restricted travel, potential hospitalization, impose real burdens on daily life, relationships, and the ability to maintain the ordinary rhythms that most people rely on for psychological stability. Support from the obstetric team, including clear, honest communication about what is known, what is uncertain, and what the plan is under various scenarios, is one of the most powerful determinants of psychological resilience in women managing placenta previa. The patient who knows exactly what to watch for, exactly when to call, and exactly what will happen under each possible clinical scenario is better equipped to manage the uncertainty than the patient who has received only general reassurance without specific guidance. There is a related but distinct condition that every woman diagnosed with placenta previa should be specifically informed about: vasa previa. Vasa previa occurs when fetal blood vessels, specifically the vessels connecting the umbilical cord to the placenta, run through the membranes across the internal cervical os. These unprotected fetal vessels are vulnerable to rupture when the amniotic membranes rupture, and when rupture occurs, the bleeding that follows is fetal blood, not maternal blood. Because the fetal blood volume is small, even a relatively modest hemorrhage represents a life-threatening emergency for the fetus. The reason this is relevant to placenta previa is that both conditions involve abnormalities of the lower uterine segment, and the prenatal ultrasound evaluation that identifies placenta previa should include specific assessment for vasa previa, particularly in pregnancies with bilobed placentas, succenturiate lobes, velamentous cord insertion, or pregnancies conceived through in vitro fertilization, all of which are associated with elevated vasa previa risk. When vasa previa is identified prenatally with color, Doppler ultrasound, planned cesarean delivery before membrane rupture converts what would otherwise be a potential catastrophe into a manageable planned surgical event with excellent fetal outcomes. The outcomes for placenta previa, when managed at experienced centers with appropriate resources, are generally favorable for both mother and baby. The majority of women with uncomplicated placenta previa deliver healthy babies at or near term without experiencing catastrophic hemorrhage. The key predictors of adverse outcome are associated primarily with complete previa persisting to late pregnancy, coexisting accreta spectrum, and the occurrence of severe bleeding episodes before planned delivery. For women who have experienced placenta previa in one pregnancy, the risk of recurrence in subsequent pregnancies is elevated, estimated at 4 to 8% in some studies compared to the baseline risk of approximately 1 to 2%. And the evaluation of placental position in any subsequent pregnancy should be specifically documented and communicated to the obstetric team. The broader lesson that placenta previa teaches is one that applies across obstetric medicine: the value of comprehensive prenatal care, of early imaging that establishes baseline anatomy, of clear communication between patients and providers about warning symptoms, and of the system-level preparedness that ensures that when an obstetric complication presents, with the urgency and unpredictability that characterizes conditions like placenta previa, the right resources, the right expertise, and the right plan are already in place. Painless vaginal bleeding in pregnancy is a warning sign. It is not a guarantee of disaster. In placenta previa, it is frequently manageable, and the outcome is good. But it is a signal that demands evaluation, that should never be dismissed, and that provides the earliest possible opportunity to identify and begin managing a complication that is most safely navigated when recognized early, monitored carefully, and delivered with preparation. The cesarean delivery for complete placenta previa, particularly in the setting of suspected accreta spectrum, is one of the most technically demanding operations in obstetric surgery. The placenta overlying the lower uterine segment and the cervix may require specialized incision planning to avoid incising through placental tissue, which would cause immediate and potentially catastrophic hemorrhage, and the surgical team typically includes an experienced maternal fetal medicine specialist, an anesthesiologist experienced in obstetric emergencies, and in accreta cases, a team prepared for potential hysterectomy and high-volume blood transfusion. Blood transfusion preparedness, including preoperative cross-match, ready availability of packed red blood cells and fresh frozen plasma, and in high-risk cases the use of cell salvage technology and interventional radiology techniques for uterine artery embolization or balloon occlusion, is an essential component of the surgical preparation for placenta previa delivery. The hemorrhage risk at cesarean for placenta previa is substantially higher than for standard cesarean section, and women undergoing this procedure at facilities with adequate blood bank resources and experienced surgical teams have significantly better outcomes than those managed at facilities without these capabilities. Understanding the specific grading of placenta accreta spectrum is important for women who have both placenta previa and prior cesarean deliveries, because the management and the surgical preparation vary significantly between grades. Placenta accreta, the most common and least severe form, involves abnormal adherence of placental villi to the myometrium without invasion into it. Placenta increta, the intermediate form, involves invasion of the villi into the myometrium. Placenta percreta, the most severe form, involves invasion through the full thickness of the uterine wall and potentially into surrounding structures including the bladder and pelvic vasculature. The more severe the accreta spectrum disorder, the more complex the surgical planning required, and the greater the potential for massive hemorrhage. Screening for accreta spectrum in the setting of placenta previa and prior cesarean is performed primarily by ultrasound using specific grayscale and color Doppler ultrasound features that indicate abnormal placentation, including loss of the normal retroplacental clear space, irregular placental lacunae, and abnormal vascularity at the uterine placental interface. When ultrasound findings are equivocal or when the clinical suspicion is high despite inconclusive ultrasound, MRI provides supplementary information about the depth of invasion and the involvement of adjacent structures that guide surgical planning. The timing and location of delivery for women with placenta previa and suspected accreta spectrum are themselves components of risk management. Delivery at a center with a dedicated accreta spectrum team, including maternal fetal medicine specialists, experienced obstetric surgeons, gynecologic oncology or urologic surgery backup, experienced obstetric anesthesiologists, and blood bank resources capable of managing massive transfusion, is associated with significantly better outcomes than delivery at a facility without these specialized capabilities. For women at elevated risk of accreta, the potential need to transfer to a higher resource center is part of the management conversation that should happen well before labor begins. Iron status management throughout the pregnancy is particularly important in the placenta previa setting, where the combination of recurrent bleeding episodes and the anticipated blood loss of cesarean delivery creates an elevated risk of perioperative anemia. Maintaining hemoglobin levels above 10 to 11 grams per deciliter entering the planned cesarean delivery, through dietary iron optimization and supplemental iron as needed, reduces transfusion requirements and improves surgical outcomes. For women who have significant anemia as delivery approaches and who have had recurrent bleeding episodes, intravenous iron infusion, which restores iron stores more rapidly than oral supplementation, may be indicated as part of the preoperative optimization strategy. The experience of bleeding during a placenta previa pregnancy, particularly the first bleeding episode, which typically occurs unexpectedly and without warning, is traumatic in the most literal sense. The sudden appearance of bright red blood with no pain to provide advance warning and no clear precipitating cause is frightening in a way that is difficult to convey to anyone who has not experienced it. And the knowledge that it will likely happen again, that the bleeding pattern of placenta previa is characteristically recurrent, adds a layer of ongoing anticipatory anxiety that pervades daily life in ways that those outside the experience rarely appreciate. The normalizing of this anxiety, acknowledging it as appropriate, not excessive, and as a rational response to a genuine uncertainty, is one of the most important things a healthcare provider can do for a patient managing placenta previa. The anxiety does not need to be cured or suppressed. It needs to be acknowledged and managed through clear information, through preparedness, and through the knowledge that a specific evidence-based plan exists for every scenario that might unfold. Color Doppler ultrasound evaluation, which we mentioned in the context of vasa previa detection, is a critical tool in the comprehensive assessment of the lower uterine segment in any pregnancy with suspected placenta previa or low-lying placentation. Color Doppler imaging allows the visualization of blood flow within and around the placenta, identification of the abnormal vascular patterns associated with accreta spectrum, and specific assessment for the fetal vessels crossing the OS that characterize vasa previa. Every ultrasound examination of a known or suspected placenta previa that does not include color Doppler assessment of the lower uterine segment is an incomplete evaluation from the perspective of current obstetric standards. The information in this video, covering the anatomy, the risk factors, the clinical presentation, the diagnosis, the management spectrum, the practical living considerations, and the related conditions, represents the complete clinical picture of placenta previa that every pregnant person who receives this diagnosis, or who is at elevated risk of it, deserves to understand. Knowledge of this condition does not eliminate its risks, but knowledge, combined with appropriate medical management and with the preparedness that comes from understanding exactly what to watch for and exactly when and how to act, is the foundation of the best possible outcome for both mother and baby. If this video gave you a clear, clinically grounded understanding of placenta previa, what it is, why it happens, how it presents, and how it is managed, please support this channel. Hit the like button right now, subscribe so you never miss a video, and leave a comment below. Tell us whether this information is relevant to your pregnancy or someone you know, or whether there is another obstetric condition you would like us to explain with this level of detail. We read every comment, and your questions shape the content we create for this community. Thank you for watching. We will see you in the next one.